Good evening friends, and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. We thank the authorities at Sion Hospital for allowing us to conduct these classes here, and we thank Aristo Pharma for an educational grant which helps us to have a live webcast of these classes. We have two cases today. First one is being presented by Dr. Aditi Shah from Sion Hospital. So we start with the case.
Good evening everyone. I am Dr. Aditi Shah and I'll be presenting the Thursday clinic case today. 3-month, 9-day-old boy, 5th by birth order, born out of non-consanguineous marriage, resident of Nashik, hailing from Patna, Muslim by religion, Sheikh by community, was brought in informed by mother who is reliable with complaints of yellowish discoloration of skin and eyes since birth, not gaining weight since birth. As there is significant antenatal and natal history, I would like to begin from there. Antenatally, it was a spontaneous conception at 32 years of age, registered pregnancy at 2nd month antenatally, 7 to 8 antenatal visits were done, 3 ultrasonographies were done in the 1st, 2nd and 3rd trimester respectively, all were said to be normal, 2 TT injections were taken, iron, folic acid and calcium supplements were started from the 2nd trimester, but the compliance was poor. There is history of fever for 2 days in the 2nd trimester, which was mild to moderate, undocumented, not associated with chills or rash, intermittent, subsided on medications, and did not require hospitalization. The fever was not associated with cough, cold, breathlessness, vomiting, or jaundice. In the 3rd trimester, mother had intense pruritus all over the body, but it was not associated with jaundice, and some lotion was given for the same. There was history of easy fatigability in the 3rd trimester and the mother was told to have a low hemoglobin, but no blood transfusion was given. There was no history of pregnancy-induced hypertension, gestational diabetes mellitus or hypothyroidism. It was a late preterm delivery, not cried immediately at birth, cried on stimulation, breech presentation, delivered vaginally with a birth weight of 1750 grams, and there is history of NICU stay for 18 days. The baby required O2 support for 15 days but was never intubated. On day of life 4, the baby developed jaundice in the form of yellowish discoloration of the eyes, face and the body and received phototherapy for the same. The baby was passing yellow urine, initially dark yellow staining the diaper, and was passing pigmented stools throughout. Jaundice was persistent throughout the NICU stay and only marginally decreased on phototherapy. On day of life 9, the baby was started on RT feeding with expressed breast milk, which the child tolerated well. On day of life 10, the baby had 1 episode of a suspected convulsion in the form of clonic movement of upper limbs. However, the child was not started on any medication for the same. There was no repeat episode of convulsion and no history suggestive of neonatal encephalopathy. By day of life 15, the baby was tapered off oxygen. Baby was started on direct breastfeeding and discharged on day of life 18. Discharge weight is not known. The yellowish discoloration was present even on discharge, which was initially in the eyes and the face, which progressively increased over the last 2 months to involve the trunk, palms and soles. As per the mother, the discoloration was initially faint yellow, which later became dark yellow. However, the child was active and feeding well throughout, but the mother noticed that the child is not gaining weight since birth. As the jaundice was persistent, the baby underwent multiple investigations and an ultrasonography was done and he was referred to Mumbai for further treatment. There was no history of pale colored stools, no history of bleeding from any side, no history of abdominal distension, no history of lethargy, poor feeding or vomiting, no history of fever or crying while micturition, no history of recurrent infections and no history of blood transfusion or blood disorders in the family. It is an unimmunized child and developmentally partial neck holding is present. He opens fists, does not coo and no social smile is present. Dietary history wise, he was exclusively breastfed for 1 month, followed by top feeding, initially with cow's milk with dilution via bottle feeding for the 2nd month, followed by formula feeding with lactodex with improper dilution since the last 1 month. Currently, he is both breastfed and top fed. In family and socioeconomic history, the mother is 32 years old and the father is 46-year-old. The first was a spontaneous abortion in the 1st trimester, followed by a 13-year-old female, followed by 11-year-old male, 7-year-old male, another spontaneous abortion which was around 3rd or 4th month, and then a 3-year-old male, and then the current pregnancy. However, there is no history, no similar history in any of the siblings or no history of any liver disease in the family. Father is a painter, illiterate and earns 8,000 a month, and mother is a homemaker, studied till 8th standard. They belong to the lower socio-economic class as per the modified Kuppuswamy scale.
So, in relevance to the chief complaints of yellowish discoloration since birth, what all can you make out antenatally? And you said 3 USGs, this, that, so all that is normal. Is that surprising to you, or the baby can still have a structural pathology or something? For example, biliary atresia, you will be able to pick up on this USG?
Not on antenatal scans, there is no sign as such to pick up any biliary atresia. Postnatally, there are some signs which can.
Why is that? If it's atresia, you should be able to pick up antenatally, no? It's like a malformation, so you should be able to pick up the malformation.
The pathology is more of acquired.
Pathology is acquired.
In the pathogenesis.
So what you want to say is that it develops over time and it is not necessarily fully developed antenatally. Okay. So that is one reason why you may not pick it up. Of course, the sensitivity of all the investigations matter, right? Now, what is, according to you, what is the relevance of this fever in the mother? Fever for 2 days in second trimester, and it was not associated with anything. So what is the relevance? Could it have been one of the infections which lead to torch infections? Could this fever have been that?
Means actually the fever is of a short duration without any association, did not require any significant hospitalization as well.
So what I'm trying to ask is, suppose you're suspecting congenital toxoplasma in a baby or congenital rubella in a baby. What classical history do you expect in the mother?
Fever with a rash and any tender lymphadenopathy, like mostly post-auricular lymphadenopathy, which is not subsiding on medication.
And more likely in first trimester.
How long should that fever be?
At least a week.
At least a week. So all 5-day fevers in mother to be ruled out as no relation with congenital infection. See, this is important because you are always asking this history antenatally. So you should know when to give it importance, when not to, what is the sensitivity and specificity of this history to link it to congenital infection, right? So the next, so one is about the duration of fever. So according to me, it need not be 7 days. It could just be even 2-3 days also. Second, what is the, how important is the rash? Suppose some mother doesn't give history of rash. So does it rule out congenital infections? No, it doesn't. So also the lymph node. Lymph node is a finding which the doctor may find, mother may rarely complain. So what we have to learn is that the maternal history strongly suggesting that the baby has got a congenital infection is very, very unlikely that you will get a nice, textbook history in the mother. You're going to get just some such things. So this neither rules in nor rules out a congenital infection. Then what about that third trimester intense pruritus? And then you said but not associated with jaundice. So what were you thinking of?
Like cholestasis in pregnancy could lead to that pruritus, but then it would have been associated with jaundice, and that is common usually in the third trimester. But it is a
Cholestasis due to? Progesterone causing cholestasis. Okay. And how common is that? And is it linked to the baby getting anything?
PFIC, generally disorders like PFIC and all, they usually have this history of pruritus in mother during ANC period.
Okay. Fine. Okay. History of easy fatigability, mother was told to have low hemoglobin. In your previous slide you said iron folic acid supplements taken. So
compliance was poor, actually she had not, but the compliance was poor to those supplements. So
correct. So important again that we may advise, but whether they are taking, so compliance has to be checked. Sir, anything so far?
I think in the antenatal history, the first thing we want to know is, has the fetus been growing well? If he's growing well, I may just collect information. Has the mother been all right? Has she had diabetes? Has she hypertension? Okay. But my interest goes down. Her obstetrician will take care of it. My immediate concern is the maternal problem affecting the fetus that is going to be born, and I would be responsible? How would I know that? Only by growth of the baby. Okay. Then of course you ask all that. Now if the growth is not occurring well, then you know that there is something wrong somewhere. Where could be wrong? Either the maternal health status, one, the placental circulation, okay, indirectly through mother, or the fetus itself. Now you start wondering whether the maternal health status was all right. There you get some fever, your antenna goes up. Has that fever been responsible? You don't know. There may not be history of fever at all, and still the mother would be infected and pass on to the fetus. And when there is a fever, even 1 or 2 days, it may not have done anything wrong to the fetus. So, history of getting fever or history of no fever doesn't lead us anywhere. But if the growth of the fetus, you said ultrasounds were done. Ultrasound is not done only for dating or only this, it's done for growth also. So we need to find out whether USG normal means is the growth normal. The radiologist's point of view, no deformities, is normal. But for us, growth is normal or not. Now you said that birth weight was 1.75, even for a late preterm, that's certainly not normal. So the growth was not occurring well. So that's number one. Second is, if there is a fever in the first trimester, as again, suppose the mother says, fever in the last trimester, does it mean any difference? Or we still go along the same, may help, make cause trouble, may not cause trouble? What's the significance of first trimester illness in a mother vis-a-vis third trimester? Any thoughts? The first trimester illness has a much lower chance of getting into trouble, but if that chance occurs, it's going to be very severe. Because it has happened at the time of organogenesis, and it could cause a lot of problem. If it happens in the later pregnancy, the chances are very high that the infection could be transmitted, but it may be much minimally damaging the baby. So again, if discharge growth has gone down, what happened in the last trimester has only hastened the delivery maybe. Okay, that anemia, whatever it is. But it would not have damaged the baby. But something happened in the first trimester could damage the baby. So that is important for us. Then you go further and find out pruritus. What are the causes of pruritus? Because the baby has jaundice doesn't mean the mother also has jaundice. So what are the causes of pruritus? And we need to ask the history, whether we can get to some probable cause of pruritus. We won't know. What are the causes of pruritus? Some thoughts?
Cholestasis in pregnancy or any viral hepatitis which the mother could have.
Simpler causes first. See, just because baby has jaundice, you can't give only liver-related causes of pruritus in mother, no? You have to start from a broad base. So suppose I ask you, what is the commonest cause of pruritus in anybody? Allergy. Scabies. Fungal infection. What else? Come on. Dry skin is extremely common nowadays, and everybody gets itching because of dry skin, right? So localized or generalized pruritus will tell you whether it's fungal infection or some other cause. So look at all these causes also besides just...
When you see pruritus, first question is, does the skin rash comes that starts itching, or does the itching start that causes skin rash? So does itch rashes or the rash itches? That's the first thing. You could have no rash and I start itching and I get the rash. The patient doesn't tell you that he started itching, he says I have a rash. And two may come so close to each other that the patient may not have even observed. Now if the rash comes first, that is itching, then often it may be local cause. And if the itching causes a rash, it often is a systemic cause. And what are systemic causes? One is of course the cholestasis, another is a diabetes. Okay. And all that happens through the autonomic nervous system dysregulation, where, as he said, the common cause is dryness. Okay. Now, what is this dryness? It may be an individual skin that you are born with, but autonomic nervous system decides sweating or no sweating. And if no sweating, you are dry. And if you are excessively sweating, then also in heat you feel uncomfortable. So autonomic nervous system disturbance may cause itching without skin rash, and it ends up with a rash. When I scratch, it ends up with a rash. Now, autonomic nervous system may come out of even anxiety, tension, so many things. What is more important here that you could have told us, what happened to that pruritus? Did it disappear? Then we forget about it. Did it persist? Then we are worried about it. Even if it persists, did it come with jaundice? It is rare for any hepatitis to come with pruritus first and then jaundice, though it's possible, because pruritus is due to retention of bile acids and a jaundice is due to bile pigments. Often bile pigments come up first, itching follows, but we may have occasionally a bile acid first appearing and then followed by jaundice, and the jaundice may be subclinical, not even seen. So I want to know the progress of this pruritus, which will tell us whether it's worth discussing pruritus in this situation. Right? Same thing about the tiredness. Tiredness may be due to varieties of reasons. Okay. But one important thing that we are worried about this child, which you came later on side, is she is a multipara. Now, multipara always has multiple problems. That's why multi-para, of course. What are the multiple problems of multipara? Now we will know which of us might be operating on this.
Anemia.
Okay, one is anemia, then
low birth weight in the child,
low birth weight,
growth.
Poor growth, then
maternal malnutrition.
okay, maternal undernutrition, yeah. Then what else?
What must be the age of a multipara? Older. What happens with
Risk of chromosomal
older age?
abnormality.
So risk of chromosomal disorder.
So many things, right? So this is a multipara. Okay. So we start wondering, has that been the cause of problem? Has there been another antenatal? So many things to look at really, right?
Also, little bit idea after the birth, we know it was low birth weight. It's not easy to find out whether the head circumference was small or no. So if there was any intrauterine problem and has resulted, there was some degree of seizures without neonatal encephalopathy, which is a good thing. It could have been just a metabolic seizure, maybe hypocalcemia. But if there was, it's difficult for mother to say the head was small or no. But by chance there was a record or something which you got, then that favors an intrauterine problem. Okay. Also the milestones. Now, the physical milestones in the baby may be less important, like head holding, etc., especially, but the cognitive milestones are important. Even if the baby is not fed adequately and undernourished, smiling, social smiling, recognizes now mother, so should come at 3 months for whatever age this was. So if that was not there, then again the antenna is up whether this baby was not normal from beginning, and at 3 months the things should have come. The weight is not there because you gave a history of poor diet, everything was diluted, so that may explain that. So that may not help so much, but always concentrate on social milestones, which are not very easy to elaborate every time.
So now we have the history after birth. So someone tell me, what is your thought process about this baby's jaundice? What is your thought process based on this history? It started on day 4 and dark yellow urine staining the diaper and stools were pigmented throughout. What are your thoughts?
Day of life 4 jaundice, we could have thought physiological jaundice also, but it is written that after phototherapy, even after phototherapy, it was persistent throughout the NICU stay. So more likely the duration is longer, as said that history of NICU stay for 18 days, then it is definitely for more than 14 days the jaundice is persisting. So it is more likely a pathological jaundice. And now
First tell me, is it direct or indirect?
direct.
So why did we do phototherapy? So that is what should have, not that we did it, but what I am trying to say is it should strike you first. For any patient, any history, your thought process is, the first branching point is first, is there jaundice? There could be other reasons for yellow discoloration of eyes or whatever. What is one other reason where there is no jaundice but yellow eyes? Carotenemia. Okay. So first is jaundice or no jaundice. High colored urine could be concentrated, blah blah blah. Moment there is jaundice, second question has to be direct or indirect. Then only you proceed further in your thinking. No? So apparently this description is direct jaundice on day 4 of life in this baby, right? So now what are your thoughts?
But there is a biphasic jaundice also, no? Direct is also gone up and indirect is also gone up. Commonly I've seen. It's not that direct bilirubin is, indirect bilirubin is normal and only the direct has gone up. Biphasic.
Mixed.
If that is so, you should give phototherapy for that indirect bilirubin problem. You must have seen all direct bilirubin reports. Indirect is also slightly higher. Direct is higher. So when do you call direct bilirubinema biochemically? I'll give you an example. Okay, you have 1.8 milligram total, of which 1.2 is direct and 0.6 is indirect. Is it direct or indirect?
Direct.
Why?
Yeah, so you were saying something. Say that.
So it should be, the direct bilirubin component should be at least 20% of the total bilirubin.
Okay. So now tell me, there is indirect also little high. So you must give phototherapy, no? That's why they have given phototherapy. They also know it's direct, but they are cleverer than us. What's your comment? Give a thought, give a thought.
Come on.
So my question indirectly is, why does a hepatocyte disease causing direct bilirubin has also some raised indirect bilirubin? On the other hand, it's a hemolytic jaundice with raised indirect bilirubin, which gets fast increasing, for which you give phototherapy. You don't give phototherapy for just any indirect bilirubin. Fastly worsening indirect bilirubin. That doesn't happen with hepatocyte. So why does a hepatocyte cause also rise in indirect bilirubin, though small?
So I think the production of bilirubin, it exceeds the hepatic capacity to metabolize the conjugated bilirubin. Not so effectively matured in such small babies. That's why we get biphasic increase in.
Very good.
Good. So it exceeds the capacity of the liver to conjugate. So that is the reason you get indirect. But what about that phototherapy question? If somebody has 10 indirect and 10 direct, for his indirect component we should give him phototherapy, no? What is the answer to that?
But with the direct hyperbilirubinemia, the phototherapy is going to be ineffective.
Is that so?
Means if the pathology...
Means does the direct bilirubin prevent the phototherapy from being ineffective? Means let's get our basics clear so that we... So does the direct bilirubin make it ineffective?
No, the direct bilirubin
doesn't make it ineffective. So what happens? So now, why do we do phototherapy? What is the purpose of doing phototherapy?
The mechanism is to excrete the bilirubin via the urine or mainly the urinary tract. If there is direct component, it suggests some obstructive pathology.
Correct. So normal bilirubin, everyday RBCs are destroyed in the body. They produce some bilirubin. What happens to that bilirubin normally? Today what is happening to your bilirubin and my bilirubin in the body? What is happening?
Getting metabolized in the liver.
So it is getting conjugated and getting excreted. Why do we do phototherapy? We do it to photoisomerize that bilirubin and make it excretable. It is not soluble in water. We make it soluble so that it can be excreted. 10 plus 10, already the body is making it excretable, no, by making 10 conjugated. Body doesn't need any help. It's just that the limit has gone up. That's why that is accumulating. Body can very well conjugate. So you don't do phototherapy, right? So this is the logic of not doing phototherapy when you have 10 plus 10, right? And it's not that direct harms or makes it ineffective, and that bronze baby syndrome is a other side effect of doing phototherapy on a baby with direct. So everything is clear. What is the logic of phototherapy and all that? Fine.
I think what happens in direct and indirect together is, indirect is very minimally raised. And why is it rising? Because the uptake of bilirubin by hepatocyte is reduced. Because hepatocyte is busy doing conversion and doing all other functions. So it cannot uptake most of the bilirubin, it uptakes. But when it goes a little beyond, a little indirect, which is always much smaller and does not need anything. I just wanted to bring a point that often there is a biphasic biochemical jaundice, but in that case, that indirect is small, and it only suggests that hepatocyte is busy with lot of other functions, that it cannot uptake every part of indirect bilirubin, and that remaining little does not bother the body at all. That is the way. And even for phototherapy, you don't start giving phototherapy moment indirect goes up. When it starts rising fast, you start considering, or when it has risen very fast already, you consider it, but not when it is much less than that, right?
So if this is direct jaundice coming up on day 4, what are your thoughts? Come on, everyone, please participate and think and talk. That's the way we'll learn. Okay, so Palniraman has corrected me. He says carotenemia, eyes are spared of yellowness. So I just wanted to ask you what is yellow but not jaundice, but by mistake I said eyes yellow, yeah. So that is. Skin is yellow, of course. Yeah.
Day 4 jaundice with direct component increased, most likely pathological jaundice. So there could be structural anomalies or there could be some other metabolic.
So which metabolic? So structural means what? Expand on that.
Structural again can be extrahepatic or intrahepatic. Extrahepatic can be biliary atresia, can be choledical cyst, can also be in bile plugs, means obstructions. Then intrahepatic, other causes can be metabolic causes. It could also be infections. It could be sepsis. It could be TORCH group of infections, intrauterine infections. Could be urinary tract infections. Metabolic mein others also endocrine causes like hypothyroidism, panhypopituitarism, and other metabolic include galactosemia, tyrosinemia. These can also cause hypothyroidism.
So if it is direct on day 4, then you have to look at that whole group and see what is possible in this baby. Now, any thoughts on that day 10 convulsion?
Could be metabolic also, hypoglycemic or hypocalcemic. Not also, there's history of not cried immediately after birth with a low birth weight, which is.
So do you think that is the cause of that 10th day seizure?
No.
Why not?
Asphyxia?
Open.
Within 3 days.
So if the asphyxia was strong enough or sufficient enough, there would have been much earlier manifestations. There are no other earlier manifestations of
Plus
poor.
only single episode is mentioned.
Yeah. So it's less likely due to that. So mostly some metabolic disturbance only.
But they should have investigated straight off, no? Nothing was done and nothing was required to be done. What kind of seizure is that? Self-limiting, single, very kind to the doctors, would never repeat again. What kind of seizure is this? We have to ascribe some cause to that, no? And imagine.
Was it a seizure to begin with, or was it like jitteriness, which is misinterpreted for a seizure? We wouldn't know because we don't know the whole semiology and the condition of the baby at that time. So.
And therefore my first question is, what are the mimics of seizures? And this is not a seizure at all. So what are the mimics of seizure? Somebody called it seizure, right? Some moments. What are the mimics?
So jitteriness, she said. Jittery baby.
Yeah. Okay. And therefore, even these movements at this age are not a common manifestation of a seizure. Often there are subtle seizures, only smacking, this, that. Therefore, luckily nothing was done. Maybe they would have looked at calcium, glucose, you are right, and then we do that. But would the hypocalcemia get better by itself? Yes. And she says no. Now you fight among yourselves, we will enjoy.
No. I mean, I also said no.
Okay.
Okay. It doesn't get better.
No, hypocalcemia does get better by itself also if there is enough calcium in your bones and the parathyroids are enough ready to act, which is not common at that age. So you are right, at that age it's unlikely, but at that age, you must have seen hypocalcemic seizures getting admitted with you, but by the time they come, the seizure has stopped. Because the body can do that.
Even for hypoglycemia, whether it will get corrected fully or no, but there are mechanisms in the body, counter-regulatory hormones will go up and try to bring up the glucose, etc. Right? So all those inbuilt mechanisms are there. Okay. Now, over the next 2 months or whatever, this jaundice is progressive and the child is active and feeding well throughout, but not gaining weight. So what do you interpret out of that?
First, we have to look at the feeds that are being given. The feed itself was inadequate.
So here, where there's a very clear history that feeds have been probably inadequate. So weight gain poor can be ascribed to dietary inadequacy. So you take it away from a point in favor of parenchymal disease or hepatitis, right? What else? Means what is the other interpretation of all this? Progressive jaundice. So what does it mean?
The disease activity is still present. It's not in the resolving trend.
So of the list of causes that we discussed, so metabolic remains, the structural anomalies remain, right? PFIC group remains. All these are progressive, right? And active and feeding well would mean what? So hepatocyte disease or biliary tract disease?
More likely a structural biliary disease.
So this, if it is right, then it goes in favor of biliary tract disease, right? And more so because we have another reason for poor weight gain in the form of inadequate feeds. Okay, no social smile present. What age? Now 3 months. So you are worried or not worried? So how much is the leeway? Every milestone has a leeway, no? 1 year walking with support or walking 1 or 2 steps. So how much leeway do you give for social smile? 6 week, 1 day, no social smile. Worried? So how much leeway? Not more than 2 weeks. So this is a very sensitive milestone, and here you don't have a very big leeway. So max to max 2 weeks leeway. If by 8 weeks there is no social smile, you are certainly, you have to look deeper, means explain the parent, are you sure there is no social smile, etc. And it would definitely be A. Then does not coo. So is that expected or not expected? I mean, does it correlate with the other things? When does cooing come? 3 months. So basically the order. So social smile followed by vocalization followed by cooing. So since you are saying there is no social smile, it's logical that there is no no cooing. So that is worrisome. Means at 3 months, if this baby definitely doesn't have a social smile.
Because younger the infant, you talk of weeks also. For somebody 2 months and 1 week is 3 months. And somebody 3 months and 3 weeks is still 3 months. So we need to be very sure what that 3 months means, right? Is it 2 months complete there for 3 months, or 3 months yet to complete there for 3 months? Both look similar, right? So just make sure about that. So what is your diagnosis now?
So my impression on history, 3-month, 9-day-old boy with history of jaundice since birth, with yellow-colored urine and pigmented stools, with significant NICU stay, with history of low birth weight, is most likely a case of neonatal cholestasis in an unimmunized child, most likely to be secondary to congenital torch infection, any obstructive cause like biliary atresia. Third would be storage disorder or hypothyroidism.
So discuss each one of them and prioritize them.
So with this history of neonatal cholestasis with the NICU stay, and we also have a history of low birth weight. So it could be a small for gestational age baby as well. So that could be seen in torch infections because they have history of like neonatal cholestasis with hepatosplenomegaly with an IUGR or a small for gestational age baby. Then second, obstructive cause like biliary atresia on history would be a little lower down in terms of having pigmented stools throughout. So there is no history as such of pale colored stools. So we cannot completely rule it out, but it would be lower down. Then again I had third with storage disorders. So to completely, like there is some history of developmental delay as yet, but no other history of seizure or poor feeding, lethargy, vomiting. So any inborn error of metabolism and storage also would not be higher up on the list. And hypothyroidism for the, mainly for the persistent cholestatic jaundice. Nothing else on history or any maternal hypothyroidism history is not there, but we cannot rule it out. So in this order only I would like to place.
First we'll ask them, then we'll come back to you. So we discussed that congenital infections do have low birth weight, so this can be congenital infection. That's not good enough, no. We need to have 3-4 points to say that, okay, this is suggestive of congenital infection in this baby. So that antenatal history, what we got 1-2 days fever, we said it's extremely non-specific. So what else is there to tell you this could be congenital infection?
History of poor weight gain.
Which you said is dietary.
Spontaneous abortion is also there. So history of spontaneous abortion, 2 spontaneous abortion.
Ah, so now you put your foot in it. So history of spontaneous abortions twice. That means you are saying she is congenitally infected for last 6 pregnancies. What are you trying to say? So which brings us to the next question. Do congenital infections recur? So infection acquired in pregnancy number 2, does it recur in pregnancy number 4?
Less likely, but syphilis can recur.
So syphilis we are not talking of. You are talking of toxoplasma and cytomegalo and rubella. You are talking of that, no? You are not talking of syphilis.
So unlikely to recur.
Okay. So multiple abortions and with in between normal children, that's not the history in favor of congenital infections.
That one episode of convulsion could also be attributed
Which
to...
we all...
Could be attributed to Touch group of infections also. They have calcifications intracranially, so could be a focus of convulsion.
We said, sir said it may not have been a seizure only, but okay. What else?
I'll give you a clue. Suppose there is a congenital infection. Is it active infection or past infection which has damaged the baby? Then we will know the duration of the problem. Okay. What do you think? Is it an active disease that I can pick up the etiology on further tests, or it is a damage occurred earlier, infection is gone, and the damage is what we are saying? What's your guesswork? Is it an acute disease or a remnant of earlier disease? Come on, give a thought, give a thought.
Maybe remnant, like
Remnant.
chronic.
Remnant.
Why do you say that?
Because even birth
Hold
weight
close,
was,
Manas,
even
hold
birth-
close.
Even birth weight was low.
No, so what is against active disease? Birth weight will be low in both remnant and active disease, because active disease also is born infected, no?
Progressive deterioration of the child will be there in case of active disease.
So it's there, progressive jaundice is there.
But the overall idea on history of a non-sick child, even though the jaundice is persistent, but the activity as described on history does not describe a sick or progressively sickening
What is
child.
the hallmark of active problem in a newborn?
Lethargy.
Not active and not feeding. This child is exactly doing that. So this is not an active disease. So this happened earlier. Okay, that much we knew. Now if it is earlier, then the question is, I said that, is it severe or not severe? Because I told you earlier that if it's severe, it must have come through very early in pregnancy. And if it was not severe, then it could have come up even later. Do you think it's severe or not severe?
Did it come up first trimester or third trimester? What do you think?
It's severe enough.
severe.
Okay, he has come at 3 months of age with progressive damage. Okay, likely to be that. Okay, though second trimester illness also comes that. So the point that we put congenital infection a little lower down because of all this. That is all. All four probabilities exist, but we are just trying to say that, whereas a biliary atresia may go a little higher and that. What about storage now? Where does it stand in our list of 4 probabilities?
So I would also, don't talk of storage and metabolic in the same breath here. Metabolic is, when you talk in the newborn period, metabolic disorders are a little different that we are talking of.
So metabolic are functional disorders, storage are functional plus also structural. Liver is enlarged, spleen is enlarged, structural plus functional. Whereas if you have a tyrosinemia, it's largely functional more than structural. Structural you can see over time. So what do you think about metabolic disorder?
So broad metabolic disorders, whether it's tyrosinemia, galactosemia or a glycogen storage disease, are they hepatocyte disorders or biliary tract disorders?
Hepatocyte.
And what did you say? Baby is non-sick.
And when the inborn error of metabolism manifests very early, it's a very severe defect and the child goes on worsening very fast. Okay, this child has not worsened very fast. Yes, jaundice has worsened, but the rest of the things have not worsened and therefore it's less likely an inborn error. Can it present right at birth? It's severe.
Not immediately at birth.
Very good. Why? They are born with a defect. So why is it waiting for 2-3 days? You are right.
Because the target organ for the enzyme defects take time to mature.
Inborn error of metabolism must have an adequate feed going inside the system to start the metabolic process, which is defective. Therefore it takes day 3, day 4 by the time real breast milk starts going in and some substance that is not processed properly starts developing. So it doesn't happen very early as you said. Okay, but day 4 could be sitting one way or another, but we said that severe defect metabolic goes very fast and this has not gone very fast in terms of multi-system involvement and therefore possibly not.
If the metabolic disease is there from the beginning, then baby should have suffered in utero only. Disease is there earlier also. Why has the baby to be born to manifest?
So
galactosemia is there from the beginning. Should have given rise to a lot of problem in utero only.
So just take what you said just now, what Amdekar sir said, that you have to have substrate. Now take this backward and answer Khare sir's question. Why?
There's no substrate in utero for the metabolism and toxic metabolites to accumulate.
So baby is being depending on mother's circulation.
Yeah, because many of the problems the mother may take over because all the metabolism is taken care by the mother. The baby is baby is dependent, not independent.
Okay, there is a
typical IM that starts very early, fools all of us. They get admitted, okay, they are often encephalopathic and we put them on NBM and IV fluids. Moment you are on NBM, no milk is going inside, metabolic process, whether there or not, starts going down and the babies are discharged after 2-3 days on IV fluids, observation and say now you are all right, go home. And at home he starts feeding again and come back after 2 days. So NBM is the first treatment and subconsciously we are doing that and the child improves remarkably. Okay, and we wonder why did the child improve so much? We don't take into consideration he improved because you stopped feeding. And by the time again that, so many times IAM is missed, patient is discharged but comes back in 2-3 days again. So keep a note of that. Something that suddenly gets better is not because of our great knowledge. because of what we are missing. Nobody gets better because we did great things. And if somebody gets better, either nature was kind or we are fools. Either of the two. Yeah.
Okay, so we said biliary atresia, but stools are pigmented, so that's a strong point. So anything similar that we can talk? There's a suggestion from the chat box, Alagili syndrome or any other syndrome. Is it possible?
That could be possible because they'll also come with neonatal cholestasis, but then other manifestations like, but we don't know.
We have to check on examination, so can't be ruled out at this stage on history.
Generally, the paucity is a slowly coming up problem. Paucity is still there, but not enough. Okay, so to that extent, that is less likely, comes a little later in life, and multiple other malformations. So that part is quite right.
And lastly,
one question, hypothyroid, indirect or direct?
Both.
Okay, both are possible, but now tell me reasons in this baby for hypothyroid and against hypothyroid, besides the jaundice. Come on.
Hypothyroidism would, if hypothyroidism would have been there, the baby would have been more sick.
Baby is active, baby would have been more lethargic.
So hypothyroid, so we're talking of hypothyroid which starts right at birth, which means the severity is also more. So in that case, these babies are dull, lethargic. And what about their feeding? They have some problem in feeding in the initial periods, right? So that is what is odd. And if at all, what is in favor from this history? I'm just making you think. We don't believe it's hypothyroid, but I'm making you think.
Development.
Yes. So you said delayed development. So that will go in favor on paper. Okay. But hypothyroid coming with isolated progressive jaundice is uncommon.
And you said that the baby was irritable, asking for feed all the time, while baby with hypothyroid, ये उठती ही नहीं है. Even if I don't feed him for 4 or 5 hours, the child is sleeping only. Also, please note that when you mention these diseases like storage, in case the examiner asks you which metabolic disease and which storage disease, you should be ready at least to name 2, 3. Maybe metabolic you will name galactosemia, tyrosmia, but I don't think of a storage disease. Which
glycogen storage, they'll give one big group and that's enough.
Many of glycogen storage disease will not, 8, 9 out of them, I don't know how many of them produce jaundice on day 2.
Correct. But as a group for passing exam, that is enough, sir.
Somebody said no, hypothyroid is a mother. If the mother is hypothyroid, what are the chances of baby getting hypothyroid? How many times you have seen a hypothyroid mother giving rise to a hypothyroid baby?
Rare chance.
Almost never. And if it is, then what is likely to be the cause? Pardon me? Antibody, but by the time it gets transferred to the baby and destroys the baby's thyroid, it's difficult. It takes time.
There's a suggestion, can it be G6PD deficiency in the baby? On the chat, there's a suggestion.
Indirect.
So direct is a strong point against, and then of course
hemolytic. No, it is hemolytic. The baby is not anemic only. So if the mother has goiter due to iodine deficiency, then the baby is also iron deficient. Endemic goiter, then only possible. Otherwise, almost never. I have not seen a hypothyroid mother giving rise to a hypothyroid baby.
Yes.
I have a dumb duck. I haven't seen a hypothyroid with jaundice on day 1. I have not seen a storage disease with jaundice on day 1. I have not seen biliary atresia with jaundice on day 1. So mostly it is
Sir, no sir, doubt is not dumb, you are absolutely right, but this was day 4, so some biliary atresias may start as early as day 4 out of that huge group, but hypothyroid and storage, you are right, and hypothyroid mainly means, see, when you have to write a theory paper and list of causes of jaundice, put hypothyroid in that list. But when you are clinically seeing a baby with jaundice, hypothyroid is your 25th or your 31st cause, not your first 5 causes, right?
So the patient is there.
Would you like to summarize the history in 2-3 lines?
माँ जी बच्चे को लेके आइए.
Let's make an attempt.
Yeah. I had this summary.
Okay, I'll make an attempt. This baby has jaundice from birth. Let's say that he is born with jaundice. Somebody who has significant jaundice on day 4, probably this baby is born with jaundice, and it is conjugated hyperbilirubinemia, and the baby has some degree of developmental disorder. So we have these 3 things that we judge. Now from here then we will see what to do. When you see it is different, and when you hear it is different.
Come, someone volunteering to examine.
So child is comfortably
Hold closer.
Child is comfortably sleeping in the mother's lap. Visible icterus is present.
Child is small for age, and overall head circumference is looking proportionate to the body. No syndromic faces. Deeply tinged icterus present over the skin.
Yes. What else do you want to look at in general examination which is relevant? You said syndromic features, means chromosomal stigmata, all that you said. You said growth. You looked at icterus. What else is relevant on general examination?
So any other stigmata of chronic liver disease?
Like?
Ascites.
Okay, so just tell her to lift up the shirt a little.
There is one umbilical hernia. The abdomen seems to be distended with visible veins. No visible, no bleeding manifestations seen.
Yeah. Anything more?
No.
So you can keep the baby there and examine if you want, or in the lap, whatever.
Yes.
What was sir doing? Fixing and following.
उस तरफ सर रखो.
Overall, AF is normal size and at level. On inspection, there is depleted icterus present, and systemic examination.
Closer.
On-
Systemic examination.
On inspection, abdomen is looking slightly distended and with umbilical hernia and visible veins over the abdomen, and
The umbilicus is pushed down in the midline.
and he is having little subcostal retractions within.
So these visible veins are proof of chronic liver disease, no?
So it should be visible and dilated veins.
Thin skin can also cause visible.
So this is just because of thin skin and has no meaning. Okay. Palpate.
Spleen. Spleen is palpable. Not allowed. Keeping tight, sir.
You want to try, Sagar, quickly? Okay, ले लो. Anything about the liver, Sagar?
So liver is palpable, 2 centimeter below the right subcostal margin. So consistency. So I could not appreciate. He was crying excessively.
Okay, fine. Come. You tell us all the findings, then we'll discuss what is the meaning of the findings.
So the child was active but not very interested in surroundings. Afebrile with heart rate of 120 per minute regular, respiratory rate 30 breaths per minute regular, saturation was 99% on room air, peripheral central pulses well felt, CRT less than 3 seconds, extremities were warm, and the sugar was 106 mg per dl. Anthropometrically, the weight of the child is 2.9 kg to an expected of 6.4 kg, less than -3 standard deviation. Length is 47 centimeter to an expected of 61.4 centimeter, less than -3 standard deviation. Weight for length is between median to +1 standard deviation. And the head circumference is 33 centimeter to an expected of 40.5. So as per standard deviation, it is less than -3 standard deviation. But when we calculate as per the Dines formula, the head circumference for the length, it is falling within normal range. So there is no microcephaly. So weight for length is actually between median to +1 standard deviation. But like the weight gain also since birth has not been adequate till now. So he would still be counted as failure to thrive only.
So how do you interpret this? 1.750 at birth, almost the same weight today, 2.5. 47, almost the length even almost hardly has gone up. Okay. So when do you think the whole problem has started in this child?
Intrauterine.
At birth? Prenatally?
Prenatal.
No, intrauterine fine, but sorry, when intrauterine? First trimester. Why?
Symmetrical.
All the parameters are reduced, so more likely a symmetrical IUG are pointed towards.
Symmetrical IUG.
So this is a symmetrical IUGR started very early. Okay, that's the thing. Do you think this child is a microcephaly? It's minus 3.8.
But
So would you call it microcephaly?
Normal for the length.
Normal for
For
this
the
child?
Length for length.
For length. Good. So, but when you have a syndromic thing, that may not really go by, and we need to look at the development of this child. And because the child was crying a little, the mother would get upset. But how do you examine neurology of such a child? You say higher functions, meningeal signs. What do you do to such a small baby's neurology? How do you examine?
General activity of the child. We can observe how the child feeds. Does he fix? Does he follow? Does he react to, means startle? Then in general, does the child just prefer to sleep? Overall activity of the child.
And what else?
What else? See, tone, almost all these babies are hypotonic. Nutritionally further hypotonic. So tone doesn't give us a lot of information. Yes, if they are spastic, maybe. Okay, so tone is not. Power is fine. Okay, so what do you examine at this age?
Neonatal reflexes.
Neonatal reflexes.
Neonatal reflex and postural reflexes. Okay, whenever you see an infant for anything, neurological examination must include that. He's a 3-month-old. So what do you expect? Has Moros should be present? Palmer grass should be present? Has an ATNR come up? What do you expect out of this child?
You said some, no? You said fist is open. So which means Palmer grass
should have means disappeared.
And what about Moro?
Moros could be present now.
Did you check? No.
No.
Okay.
Was there asymmetric posture?
When does the asymmetric tonic neck reflex disappear?
5 months.
4 to 5 months. Because after, or 4 months, because that is when the baby then can roll over, right? Okay. Now, continuing with that, see here the length is quite bad, and the baby has a umbilical hernia also. So we were wrong on history. This is hypothyroid. Correct, no? Short stature and umbilical hernia and
Again, same, but he's not that lethargic.
And
height, weight, everything is proportionately affected in hypothyroidism.
It's not just the height which is strikingly out of proportion.
On head-to-toe examination, skull is normal in shape and size. Dilated veins over the scalp were seen. AF is open and at level 1.5 into 1.5 centimeter. Generalized icterus is present all over the body, including face and eyes. Some dry, scaly, reddish lesions were present over the forehead. There is no facial dysmorphism. Ears and nose are normal. Chest and trunk is normal. Abdomen is distended with visible dilated veins, and umbilical hernia is present. Spine and genitals are normal. On systemic examination per abdomen, on inspection, abdomen is distended more in the upper quadrant and moves uniformly with respiration. Dilated visible veins are present over the abdomen. Umbilical hernia is present. No scars, sinuses, and visible peristalsis. Flanks are not full. Genitals are normal. On superficial palpation, no guarding tenderness, rigidity. On deep palpation, liver is palpable 4 cm below the right subcostal margin. It is soft, smooth surface, rounded margins, and left lobe of liver is also palpable with a total liver span of 6 cm. Spleen is palpable 5 cm below the left subcostal margin. Firm in consistency, smooth surface, and splenic notch was felt. Tympanic note is heard over the entire abdomen, and on auscultation, bowel sounds are heard. Rest of the systemic examination is within normal limits. Cryotone activity good. On RS examination, air entry bilaterally equal and clear. No adventitious sounds were heard. And in CVS examination, S1, S2 was heard. No murmur was appreciated. So, final impression. 3-month, 9-day-old boy is a case of splenohepatomegaly with neonatal cholestasis with significant history of NICU stay with failure to thrive, with an unimmunized state with faulty feeding, most probably secondary to a congenital torch infection without any features of a decompensated liver disease.
How do you explain liver and spleen? We said it's not an active disease. Okay, it has started way back. Why is the liver and spleen enlarged?
Sir is asking, why is there a liver and spleen in this baby?
Liver, the hepatomegaly and the neonatal, the cholestasis could be explained. But for the spleen, also if it was if it is a congenital torch infection, then splenomegaly is present in those cases.
What do you mean by dilated veins? So let's start from there. Spleen is abnormal. Is liver abnormal or not abnormal? Or within normal limits?
Span is also 6 centimeters, so that way as
But function of the liver, no? So there has to be abnormal liver, no? How can you call it normal liver?
Okay, so liver is abnormal. Okay, in an abnormal liver there is a spleen, and in an abnormal liver there is jaundice. Now put all these together. Okay, there's a storage disorder like Gaucher's, Niemann-Pick's, whatever. Do they have jaundice? No. Or they should not have jaundice? They have jaundice. At what stage they have jaundice?
when there is decompensation of that liver disease.
So to begin with, for a long time, there may not be any hepatocyte dysfunction, but at the fag end, the child has already started hepatocyte dysfunction. Now in the light of that, suppose I call it cirrhosis. Do you have any objection? It's a liver disease, it's a chronic liver disease. Okay, there is a splenomegaly, there are dilated veins. I'll call it cirrhosis.
For cirrhosis, there is no hepatocyte function defect like edema or ascites or bleeding disorder.
See, the point is, this child we have already said is 3 months old. Possibly the story started very early in pregnancy. So add another 6 months. It's already 9-month-old liver disease. It's long enough to get into complication. Okay. So the question is this therefore equivalent to cirrhosis? Let me ask you another question. If you have a typical biliary atresia, okay, when do you see this biliary atresia coming to you with cirrhosis? Therefore, the surgeons bark at us and say, give us very early. Otherwise, they will come with cirrhosis. What age does that happen? That happens between 3-4 months. In fact, they want us to be there before 15 days, if you like.
So she's saying that multi-system is not affected in the liver. That's why not cirrhosis.
No, the question is it compensated cirrhosis or decompensated? When it becomes decompensated, you get, what is decompensation? Ascites or a coagulation defect or an encephalopathy. But if this child is hypoalbuminemic, it's not called decompensated, it is still compensated. So what's the difference between compensated and decompensated? Compensated is nature is trying to maintain the vital functions through the liver as much as possible. That is compensated. When that starts failing, you get encephalopathy, you get bleeding, that is decompensated.
From the chat, there were a few suggestions. So one was you must also look for cataract in your examination. Then hypothyroid, there would be puffy eyelids and protruded tongue. Yeah, those are the other suggestions. And Palniraman sir has said that glycogen storage presents later, not so early.
On investigations, the CBC HB of 7.4 with WBC 22,400, which was equal lympho and neutrodominant, and platelets were 2 lakh, hematocrit of 25.1, MCV 86.6, MCH 25.5, and MCHC 29.5 with retic of 3.1%. The total bilirubin was 10.2 with direct component 6.4, SGOT, SGPT of 295 and 145. Total protein 4.9, albumin 3, and PTINR was 16.2 and 1.23. RFT was 5 and 0.4. A thyroid function test was done, which was free T3 was 2.56, free T4 0.88, TSH 5.79. Ultrasonography pre and post feed was normal with 90% contractility index, and hepatoportal Doppler was normal. A 2D echo was done as well, suggestive of 3 mm OS-ASD with a left to right shunt. The torch titers were sent. The CMV IgM was 173. However, blood CMV PCR is sent, which is awaited. And that's.
You done the mothers?
No, mothers is not yet done.
Why do you want mothers?
Means
Babies is enough, no? Mothers is already, she doesn't have jaundice.
The like the IgM and IgG titers of the mother we could see, to see if she.
So what do you want to see in the mother?
If she has IgM active infection or fast.
G positive and IgM positive, and what's the difference between one of the two is positive and if both are positive? Can somebody quickly tell me? Forget this child. What is IgG? What is IgM? What is both together? Come on, give a thought. I'm sure you know it. Okay. Somehow when we ask a question, you feel it must be something weird and difficult. No, it must be very simple sometimes.
Maybe you can tell us for dengue and then we'll come to CMV if you want.
Correct.
If you're more comfortable.
In dengue we do that, no? IgG, IgM. Why? IgM is enough.
Come on. Dengue IgM positive means what?
Recent infection.
Dengue IgG positive means what?
Means past infection.
Bas, you should ask one question. Before answering what dengue IgG means, you should ask in what titer. So dengue IgG low titer or dengue IgG high titer. So dengue IgG low titer is okay, past infection. High titer is recent add-on to that old infection, right?
So I think if you don't have IgG here, it almost means that this child has recently got infected, which is unlikely. So this child must be also IgG positive. If it's a congenital, then the mother is also still IgG positive. She may not be IgM positive. So I want the mother's positive report and the baby's both IgG and IgM positive.
Mother's IgG will be strong positive.
Strong positive. Okay, yeah.
Thank you.
Fine, but good presentation.
So we have actually started Van.
What is the natural history of it? My close friend's daughter was to give birth to a child, and their obstetrician went abroad.
So at midnight they landed to my house from 100 kilometers. She was born in my place. She was with us for few months, 2 weeks, and they went to Rajasthan in Pilani. And after 6 months the baby had problems. And the pediatrician sent them to Bombay, and that turned out to be CMV. That child is mentally retarded and bad. She got IV ganciclovir. But we did not, she wasn't staying with us, but we had no idea at all for the first 2 weeks.
We should also try and summarize. When we ask you to summarize, you just go on enumerating the abnormality, small for date, etc. Summary means logical explanation. So may we attempt, this particular baby was IUGR, has presented from jaundice from birth. The bilirubinemia was of the conjugate variety, and in addition to this particular baby has hepatosplenomegaly. There is no evidence of portal hypertension to explain the splenomegaly. So it suggests that both hepatosplenomegaly are part and parcel of a same disease which is likely to be infection. So this baby probably has congenital infection giving rise to hepatosplenomegaly, jaundice from birth, delayed development. Therefore this is how, so though he presented as hyperbilirubinemia, all these things have to, and you have to give the sequence and logic for that. It is not easy to summarize. Enumerating is easy, but logically explaining is not always easy.
Good evening, everyone. I am Sunakshi Shravane. I am going to present a short case. There was 10 years old girl, first by birth order, born out of non-consanguineous marriage, resident of Mulund, hailing from UP, Hindu by religion and Buddhist by community, brought by father with chief complaints of oral bleed.
I think being a short case, we will give a diagnosis now only. Then we will see what she has to say. Okay. Start giving me a diagnosis. And also tell me what do you expect on examination, what do you expect more, whatever. Okay. We'll go by normal things. Certainly anything might happen thereafter. We don't know the story. Good enough for us to discuss. Come on, who will start?
We just discussed liver disease, no? So this is chronic liver disease which has decompensated and come with a bleed.
It's an acute history of only oral bleed since 2 days. So can be platelet disorders with mucosal bleeds.
Okay. Platelet disorder with mucosal.
So I think first thing you could start saying, if this is a healthy child, this is what is likely. If this is a sick child, what is this likely? Okay, we haven't seen whether he's sick or not sick. Okay, if it's a healthy child, what is your first diagnosis? Healthy child comes with this acute onset, 2 days, 1 day.
Platelet.
Platelet.
If it is
okay.
healthy.
And what platelet? Destruction, peripheral destruction, poor production.
You can add the word acquired. Recently acquired platelet disorder may be functional, may be numerical. That means thrombocytopenia or thrombocythemia. But he has rash on the body. Now we are not given the distribution. So what is more likely?
ITP.
ITP.
Okay, ITP.
Okay. Anything else?
HSP, a palpable purpura, but just for the rash part.
Okay. HSP. Okay. Fine.
Could be ding.
What we want to say is that if he's healthy, then is he sick healthy or a comfortable healthy? That's my next thing. If it's a comfortable healthy, you are talking about maybe an acquired thrombocytopenia. Could it be thrombocythemia? Also healthy, not sick. What do you think? Could it be thrombocytopenia?
What about the presentation?
It would have been an earlier presentation since it is a inherited disorder.
That may not be. It can manifest at any age. But what else in presentation is against thrombasthenia?
Trauma.
No. The severity with which it has presented, all over the body rash in one day, why should it be thrombocythemia?
And thrombocythemia rarely presents with bleeding, it presents with just some few ecchymotic patches here and there. So this is thrombocytopenic and healthy, not sick, so acquired, autoimmune, whatever. And if he's sick, then?
Can be leukemia or...
Now take a note. If he is acutely sick, he would not have been only saying this. He would have said, he's very highly high fever, he's not eating, she has not said anything. So this must be a chronically sick child, but not acutely sick. So this is not a bone marrow, leukemia or whatever. Could it be a chronically sick child who has come with bleeding?
Chronically sick child with these acute decompensation could be the presentation.
And therefore, chronic liver disease doesn't come with rash all over the body, not bleeding only through this. Then if it's any other acquired disorder, chronic, somebody said HSP, etc., it doesn't come with bleeding like this. It may come with thrombocytopenia, but there is something else also. So this must be a healthy child with autoimmune. Okay, is our first impression. Okay. Now let's see what she is going to say. See, it's fun to start thinking, and we could be totally wrong. Who asked you to give a diagnosis only with this? But I know when Anand Shandile used to be with us, he would say that some patients come and say, क्या होता है? आप ही देख लो ना, आप डॉक्टर है ना. So some people don't want to say what is wrong. She has told us enough, right? Come, tell us.
Can you rule out henoch-Schönlein confidently? No.
Yeah, in this history you can. Do they bleed? They don't, no? So in this history you can rule out HSP.
Child was alright 2 days back when she complained of multiple red colored spots inside her mouth, on the inner part of the cheeks and upper surface of the mouth, which were spontaneous in onset, multiple, approximately of the size of pinhead, associated with minimal bleed on touch and not associated with pain. Parents took her to a local practitioner where some oral medications were prescribed. Next day she started developing small dark purple colored spots all over the body not associated with bleeding or itching or pain, for which she was brought to the Sion hospital. On inquiry, child was also passing red colored urine and black colored stools since one day. There were no other bleeding manifestations present. There was no history of fever, joint pain or retroorbital pain to rule out dengue. There was no history of intake of any other medications to rule out any drug history which can predispose thrombocytopenia. There was no history of joint swelling or restriction of joint movements or easy bruisability. There was no history of blood transfusions. There was no history of jaundice or edema. There was no history of cola-colored urine or decreased urine output. There was no history of abdominal pain, bone pain, or any weight loss. There was no history of bleeding disorders in the family, and child has not attained menarche yet. Past history. There is no history of similar complaints in the past, but there is a history of cold, cough and fever 15 days back that resolved within 3 to 4 days. ANC history is not significant. Registered pregnancy, took iron folic acid tablets, took TT injection, 3 scans were done to be normal. There was no history of fever with rash during pregnancy. Birth history, full-term normal vaginal delivery. Baby cried immediately after birth, 2.9 kgs weight. No NICU stay, birth vaccines were given. No history of bleeding from umbilical stump. The child is immunized till date. Dietary history, eats from the family pot. Developmental history, child is appropriate for the age, good scholastic performance in school, studies in 5th standard. Socioeconomic history belongs to the lower middle class as per modified Kupus-Huami scale.
I think she has given an excellent negative history for the first time. Show us our negative history. So well done. It's not a long list. Look at that. She is talking about justifying every one, thing. Excellent.
And so she is presenting for the first time.
Yeah, excellent. I think every time he asks you, why did you ask it? And he convinced you few things that you may not have asked. Look at her. Everywhere she has put down in the bracket. Okay. Very much. I am impressed by that. Yes, absolutely. I mean, we have not had any such beautiful negative history. I must say that. And I must congratulate. Even I may not have done it. You have done it. So, very good. No, don't you think so? What a perfect. She has given us all that. Excellent. Very good. I am impressed.
Okay. Now, if you were listening to the history, anything that struck you कि ये तो ITP में नहीं होता है?
The red colored urine.
Okay.
Melina also unlikely in
So melena and red colored urine or hematuria are not, fitting with ITP. So now start thinking, what could it be? Means suppose either that melena is wrong or that hematuria is wrong, and if it is, then what does it mean, and then how will you fit everything? What does it mean? Melena would mean what? What kind of a bleed?
mucosal bleed.
Some form of mucosal.
Mucosal bleed, but
Large amount.
large amount. So it has to be a vessel bleed rather than just a mucosal bleed, right? That's not enough to cause melena. And what about hematuria? Hemolysis would give you cola colored, like a G6PD intravascular hemoglobin, all that will not be red. Red urine is fresh blood in urine or hematuria, right? Glomerular hematuria is also cola colored. So red urine is lower urinary tract, fresh blood. And if without pain, that means painless hematuria from the lower urinary tract, which is very odd. It is not fitting in. But my main thing was even melena, you can't get so much blood just in ITP for melena, right? So incidentally, for discussion's sake, any coagulation disorder with a platelet problem?
Some type of von Willebrand disease.
Very good. So von Willebrand's disease is something where you can have both. Now again, they will not come with a sudden manifestation of all these platelet manifestations all over the body, but to think about.
Could it be multiple malformations, capillary malformations, multiple, they are bleeding. Okay, child is healthy.
But hematuria.
First thing, why should they
Very
bleed suddenly? Second thing, why is there a purpuric spots or whatever? And therefore, something is amiss. But what she has mentioned is no history of cola-colored urine or decreased urine output. So is it a red-colored urine and not cola-colored? That means really a bleeding from collecting system, and that doesn't fit in at all. Though I recall, and I'm sure Rajesh you recall, that in one of our meetings somewhere, somebody who was a better knowledge of hematology said that, sir, once I remember to have seen even hematuria in a platelet disorder. Okay, but he was only one that we have met, and that one has seen only once in life, so we have forgotten that. Okay, but you remember that, yes.
Okay, go on. Examination. Or your impression on history.
A 10-year-old girl presenting with ecchymosis and purpura with spontaneous bleeding manifestations is likely to be a case of acquired bleeding disorder. To rule out immune thrombocytopenic purpura, leukemia, marrow failure, or wall-Wilborn disease.
So leukemia, marrow failure would be sick children.
Sick children.
This child is
Not sick.
not sick.
On examination, child is fairly built, conscious, cooperative and well oriented with time, place and person, afebrile, pulse rate is 100 per minute, respiratory rate is 28 per minute, BP is within 58 to 98 centiles. Saturation is maintained, peripheral pulsations are well felt and extremities are warm. Anthropometrically, child is normal. Head to toe examination, head is normal in size and shape, no obvious facial dysmorphism. Ecchymotic patches is seen in the buccal mucosa and on the hard palate. Eyes. In eyes, there is subconjunctival hemorrhage present. Palpable purpura present on limbs, chest and abdomen. Genitals are normal.
One minute, let the picture be. Okay.
Systemic examination, RS errantry bilaterally equal, no adventitious sounds heard. CVS S1 S2 heard, no murmur. CNS tone power reflexes were normal. Per abdomen soft, non-tender, no organomegaly. To summarize, 10 years old girl presenting with ecchymosis in the buccal mucosa and on the hard palate, and palpebral purpura on the body with subconjunctival bleed with no organomegaly in a birth and developmentally normal, fully immunized child is most likely a case of immune thrombocytopenic purpura, marrow failure and leukemia. But
what does palpable purpura mean? Does it have a separate significance than a normal purpura?
Palpable are usually vasculitic.
So you have to think of vasculitis. And what is the changed name of enoxonlin purpura? IgA vasculitis. Okay. So do you think this is enoxonlin or IgA?
unlikely.
Why?
Distribution of the palpable purpura, no abdominal pain and or any joint pain.
If they are present, yes. If they are absent, you can't be too sure.
But the rash is very classical of lower limb.
Yeah, so in most of IgA that is true, but again, like sir was talking about exceptions, there could be some henoxonlin where the rash extends beyond the lower limbs also. But what is one test, just one test, which will differentiate the two? A blood test. But in only one test, you are allowed only one test. What will you find? Huh?
HSP will
Yeah,
not have thrombocytopenia.
yeah. So normal platelet count and low platelet count, na, simple. So that's the biggest difference between the two, right?
If it is ITP, then why is the purpura palpable? She may be right. But there is ecchymosis also there. So what she is palping is actually a subcutaneous or cutaneous bleed more than inflammation, which is palpable.
So on investigating the child, on presentation, hemoglobin was 12.4, hematocrit was 39.3, WBC was 9,860, platelet count was 31,000. On the next day itself, the platelet count dropped to 2,000. Then we also did Cox workup. Monto came out to be positive, and USG RPLN suggested of multiple subcentimetric necrotic lymph nodes in pre and para-aortic and aortocaval lymph nodes. GLG did not show MTP growth. DCT ICT was negative. OLD was negative. Stool RM showed occult bleed. Urine RM was NAT. Complete bleeding profile was within normal limits. So on CBC with PS, the absolute eosinophil count was raised. So we went for a bone marrow under the platelet cover. So bone marrow report was suggestive of ITP with hypereosinophilia. So for that we started IVIG. It was given 2 grams per kg. Repeat CVC was done, and there was increasing trend in the platelets, and child was discharged on AKT.
You gave us the anthropometry of this child.
No.
And are there any symptoms prior to this, any complaints prior to this rash and all that?
No, child was all right.
Okay. So, first about the ITP. So, anything on the peripheral smear that will tell you that the bone marrow would be normal, you expect it to be normal. Very good. Megakaryocytes on peripheral smear, right? And what is this immature platelet fraction?
So in ITP there is peripheral destruction. As a response, the marrow is stimulated. So the IPF is high. As soon as the treatment is initiated, once the marrow is suppressed due to the recovering platelets, the IPF goes down. So
any crude equivalent of IPF on your normal CBC?
MPV.
Mean platelet volume. So if the platelet is larger, it is immature. So even that mean platelet volume, if it's in that higher side, that's also a clue that there are young platelets in circulation. Anything else? What is RDW? So is there something like a PDW? There is platelet distribution width. So the wide platelet distribution width will tell you that there are different size platelets, which again means that there are young platelets in circulation, right? So these are indirect clues on the CBC that production of platelets is normal, right? And I mean, this case aside, but what about the lymph nodes and the MAN2 positivity? How would you normally approach them, approach these two phenomena? So first of all, is ITP related to tuberculosis? So it's just part of your routine screening that you picked up some investigations. So 10-year-old, no? Yes. So how would you interpret MAN2 positive in a 10-year-old? Forget this child in general. Which is at all ages, it is not age dependent. Induration more than 10 is not age dependent, it is MAN2 positive, more than 10. What is your interpretation?
May have acquired subclinical infection in the past. Exposure.
So actually it just means that this person has been exposed in the past, full stop. Whether he still has germs, whether he is infected, whether he is diseased, it means nothing, right? So that's one. What about the lymph nodes? So again, on a different note, if somebody comes with a USG report which shows you some lymph nodes, how will you approach that?
The necrotic lymph nodes could be seen in leukemia as well, in malignancies. So
no, so I'm now bringing my starting point as a patient who comes to you, doctor, I got this USG abdomen done and it's showing lymph nodes.
Size of the lymph nodes. Size.
Straight size.
Features.
Huh? First clinical, no? What is wrong with you? Why did you do a USG abdomen? And if there is no abdominal symptom and you did a USG, then your way of looking at that USG only changes, na? So first, whether there are any symptoms at all belonging to the abdomen, right? And then all these points about the architecture, the size, whatever. And that necrotic is again not a very dependable finding. So just that does not mean that it is caseation and it favors tuberculosis, no, right?
I think multiple small lymph nodes in an asymptomatic child only indicates that it's a burnt out disease. Who doesn't have multiple cervical lymph nodes? Small, but asymptomatic. So this child had some aortic, para-aortic, whatever, and no symptoms whatsoever. So you would not even investigate them further. Okay. We were discussing whether bone marrow was necessary, but yes, hematologists would be better off confirming that, but we have had enough peripheral evidence that bone marrow is working well, so we could have even got out of it. Of course, if you were to give steroids, etc., you have to be very sure that the bone marrow is normal. But I think another plus point, what she showed was even the photographs. Wonderful. What's my conclusion? If you are a junior, you are committed to do something with whole heart. Once you start getting senior, you say, oh, it's useless wasting time. I saw her when I walked in, she was still reading. Right? Yes. And the way she presented, I am convinced that more senior you are, more likely you are going to miss something. And what's the lesson that she taught us? Even if you are senior, behave like a junior, which means you don't know enough and you will go systematically. Isn't it? I think excellent. We haven't had such a wonderful presentation for a long time, and she has taken extra efforts. Okay. I'm sure she is a little more busy than some of your seniors. Yeah, you make her work more, you order, but even then she has found time. So I thought that is a lesson for all of us, including me. Yeah.
Okay, any questions? So at that 2000 platelet count, we should have given 1 hourly platelet transfusion, no? No? 2000 platelet count.
Platelets.
So no point in giving platelet transfusion. So when do you give platelet transfusion in an ITP?
Life-threatening bleeds. In life-threatening bleeds, you can give as in intracranial bleeds. Any
Okay.
massive other bleeds.
Fine. So no role of platelet transfusion. Yeah. Fine? Okay. Thank you. I think we stop here. Thank you everyone for participating actively. Today we had much more active participation from the net also. So thank you all students and faculty on the net. And we meet once again next Thursday at 6 p.m. Thank you. Sir. Rice.
You go. No, you do it. Please do it.
So we'll just summarize both the cases today. So the first case we saw was of a 3.5-month-old infant, born a little premature, born low birth weight, with some antenatal history which we did not have a very clear-cut significance to. And then from day 4, progressive direct jaundice with something else in the history, that there seemed to be delayed cognitive milestones, right? So we discussed whether this is a biliary tract disease or a hepatocyte disease. We were more in favor of a biliary tract disease because this baby was active, feeding well, though the feed itself was diluted. That's why this baby didn't put on much weight. And then on examination, we found that this baby is a symmetric IUGR because all the 3 parameters, length, weight and head circumference, were very low for age, and therefore we realized that this is something that has happened long back in the intrauterine period. That strengthened the diagnosis of a congenital infection, plus of course the finding of hepatosplenomegaly, right? So that was our first case. On investigations, looks like CMV, but we still awaiting confirmative investigations. And the second one was a 10-year-old with 1-day onset of rash all over the body, which looked like a petechial rash. So in a healthy child, straightforward the diagnosis is ITP, which was confirmed on examination, And then we discussed how a CBC itself can be a strong clue to whether the platelet production is normal or no. And we revised the fact that in ITP it is useless giving platelets because they'll be destroyed, right? Thank you very much. Thank you once again all our online viewers and faculty, and we meet once again on next Thursday 6 p.m. Thank you.